Impacts resulting from COVID-19 pandemic crisis. In 2020, at the initial onset of the crisis, the Families First Coronavirus Response Act, or the FFCRA, was enacted on March 18th of 2020, and the Coronavirus Aid, Relief, and Economic Security Act, also known as the CARES Act, was enacted on March 27th of 2020. These laws required individual and group health plans, including insured, self-funded plans, and grandfathered plans, to provide first dollar coverage for testing of COVID-19, both in and out of network. Also, any related services that are received during emergency room, urgent care facilities, or in-person or telehealth visits for other respiratory illnesses performed while an individual was being assessed for coronavirus were also covered. The CARES Act provided for coverage for vaccines, which were subsequently developed without cost share as ACA preventive services. So the COVID vaccine is a preventative immunization, like it's preventative, covered at 100%. Regulatory pronouncements sanctioned the use of telemedicine in responding to the crisis. The CARES Act clarified that telemedicine and remote services would not jeopardize health savings account eligibility by allowing high deductible health plans to cover a broad range of services without regard to whether the deductible was met. So people were able to use their health savings account before their deductible was met. The Consolidated Appropriations Act of 2021 was passed, and this wide-ranging legislation included multiple acts providing various forms of COVID-19 relief, funding for testing and vaccine distribution, economic relief for businesses, and various tax changes. Nearly all of the tax changes were found in the COVID-19 related Tax Relief Act and the Taxpayer Certainty and Tax Relief Act of 2020, with some additional changes found in the Economic Aid to Hard-Hit Small Businesses, Nonprofits, and Venus Act and the No Surprises Act. The legislation was signed into law on December 27th of 2020. So again, the No Surprises Act legislation was signed into law on December 27th of 2020. The No Surprises Act provides protection against surprise medical bills. Patients treated for coronavirus-related symptoms, that were treated by an out-of-network provider would not be charged out-of-network costs. They would pay the in-network costs. An arbitration process was created to help resolve payment disputes between insurers and out-of-network providers. The Act also has some protections for continuity of care temporarily when a provider changes status from in-network to out-of-network. This legislation also promoted compliance with mental health parity requirements by mandating that insurers and group health plans perform and document comparative analysis of the design and application of non-quantitative treatment limits, or NQTLs, on mental health or substance abuse disorder benefits. Effective January 1st of 2022, insurers and group health plans are required to offer a price comparison tool either online or by the phone so enrollees can compare cost-sharing amounts between providers. Consumers are also to receive an advance explanation of benefits that must explain whether the provider is in or out of network, include good faith estimates of costs, cost sharing, and progress towards meeting the patient's out-of-pocket maximums and deductibles, and make certain disclaimers. Insurers and group health plans must verify and update provider directory information at least every 90 days and remove any providers where information is unverifiable. They must also respond to participants about a provider's network status within 1 business day of a request and maintain a database of in-network providers. There is cost-sharing relief to participants who would incur higher costs because of reliance on inaccurate information in an insurer's or group health plan's database, provider directory, or response protocol. Accordingly, the insurer group health plan cannot impose cost sharing in excess of the in-network cost sharing. Any cost sharing must also be applied towards the enrollee's deductible and out-of-pocket maximums as if the service were provided by an in-network provider. If a provider charges a patient a higher amount based upon out-of-network cost sharing instead of in-network cost sharing, and the participant pays the bill, the provider must reimburse the enrollee for the excess amount the plan, including interest. Gag clauses were also implemented, and these gag clauses restrict or prevent insurers from making price or quality information available to patients or other third parties. Group health plans and insurers offering group coverage also cannot contract away their right to electronically access the identified claims and encounter information or data for enrollees. Providers are permitted to place reasonable restrictions on public disclosures of this information, but insurers and group health plans must retain access to this information. Compliance with the ban on gag clauses is enforced through annual attestations submitted by insurers and group health plans. Prior to passage of this ban on gag clauses for insurers and group health plans, such bans and contracts were previously implemented by Congress between pharmacies and insurers or pharmacy benefit managers. Prior to this congressional action, such gag clauses had prevented pharmacists from disclosing cost information to patients. Insurers and group health plans must submit data on pharmacy benefits and drug costs to federal regulators annually. This data includes, for instance, each plan's 50 most costly drugs, as well as the 50 drugs with the largest increase in plan expenditures over the prior year, total spending on health care services, average monthly premiums, and any impact on premiums from rebates, fees, or other remuneration paid by drug manufacturers. This information will then result in the government biannual report on prescription drug reimbursement, pricing trends, and the role of prescription drug costs in contributing to premium increases or decreases. On March 11, 2021, the American Rescue Plan Act of 2021 became law. This legislation included additional funding for rural hospitals, healthcare providers for COVID-19 relief, increased federal subsidies for COBRA coverage, and changed the Medicare wage index for purposes of Medicare hospital payments. It also allocated additional resources for the COVID-19 response and provided funding for worker protection activities. It also provided federal subsidies valued at 100% of the health insurance premium for eligible individuals and families to remain on their employer-based coverage. This provision was applicable until September 30th of 2021. Similarly, the law reinstated until September 30th, 2021 tax credits for employers who voluntarily covered the paid family and medical leave provision that were established by the Families First Coronavirus Response Act, but had expired on December 31st of 2020. The near immediate transition to providing various medical services and consults via telemedicine for a variety of medical specialty areas has ushered in a whole new era in healthcare. It is evident that the clock will not be turned back on many of the new uses of technology that extended the reach and potentially expanded services available to legions of geographically dispersed patients. The past few years have dramatically impacted insurers, group health plans, and employee medical benefits from both regulatory and medical practice perspectives. This all happened as a result of the coronavirus pandemic.